Indications. Xolair, omalizumab, is indicated for adults and pediatric patients 6 years of age and older with moderate to severe persistent asthma who have a positive skin test or in vitro reactivity to a perennial aeroallergen and whose symptoms are inadequately controlled with inhaled corticosteroids. Limitations of use. Xolair is not indicated for the relief of acute bronchospasm or status asthmaticus. Add-on maintenance treatment of chronic rhinosinusitis with nasal polyps, CRS with NP, in adult patients 18 years of age and older with inadequate response to nasal corticosteroids. The reduction of allergic reactions, type 1, including anaphylaxis, that may occur with accidental exposure to one or more foods in adult and pediatric patients aged 1 year and older with IgE-mediated food allergy. Xolair is to be used in conjunction with food allergen avoidance. Limitations of use. Xolair is not indicated for the emergency treatment of allergic reactions, including anaphylaxis. Chronic spontaneous urticaria, CSU, in adults and adolescents 12 years of age and older who remain symptomatic despite H1 antihistamine treatment. Limitations of use. Xolair is not indicated for treatment of other forms of urticaria. Important safety information. Warning: anaphylaxis. Anaphylaxis presenting as bronchospasm, hypotension, syncope, urticaria, and/or angioedema of the throat or tongue has been reported to occur after administration of Xolair. Anaphylaxis has occurred as early as after the first dose of Xolair, but also has occurred beyond 1 year after beginning regularly administered treatment. Because of the risk of anaphylaxis, initiate Xolair therapy in a healthcare setting and closely observe patients for an appropriate period of time after Xolair administration. Healthcare providers administering Xolair should be prepared to manage anaphylaxis, which can be life-threatening. Inform patients of the signs and symptoms of anaphylaxis and instruct them to seek immediate medical care should symptoms occur. Selection of patients for self-administration of Xolair should be based on criteria to mitigate risk from anaphylaxis. Contraindications. Xolair is contraindicated in patients with a severe hypersensitivity reaction to Xolair or to any ingredient of Xolair. Warnings and precautions. Anaphylaxis. Anaphylaxis has been reported to occur after administration of Xolair in pre-marketing clinical trials and in post-marketing spontaneous reports. In pre-marketing clinical trials in patients with asthma, anaphylaxis was reported in 3 of 3,507, 0.1% patients. Anaphylaxis occurred with the first dose of Xolair in 2 patients and with the 4th dose in 1 patient. The time to onset of anaphylaxis was 90 minutes after administration in 2 patients and 2 hours after administration in 1 patient. A case control study in asthma patients showed that among Xolair users, patients with a history of anaphylaxis to foods, medications, or other causes were at increased risk of anaphylaxis associated with Xolair, compared to those with no prior history of anaphylaxis. In post-marketing spontaneous reports, the frequency of anaphylaxis attributed to Xolair use was estimated to be at least 0.2% of patients based on an estimated exposure of about 57,300 patients from June 2003 through December 2006. Approximately 60% to 70% of anaphylaxis cases have been reported to occur within the first 3 doses of Xolair, with additional cases occurring sporadically beyond the 3rd dose. Initiate Xolair only in a healthcare setting equipped to manage anaphylaxis, which can be life-threatening. Observe patients closely for an appropriate period of time after administration of Xolair, taking into account the time to onset of anaphylaxis seen in pre-marketing clinical trials and post-marketing spontaneous reports. Inform patients of the signs and symptoms of anaphylaxis and instruct them to seek immediate medical care should signs or symptoms occur. Once Xolair therapy has been established, administration of Xolair pre-filled syringe or autoinjector outside of a healthcare setting by a patient or a caregiver may be appropriate for selected patients. Patient selection, determined by the healthcare provider in consultation with the patient, should take into account the pattern of anaphylaxis events seen in pre-marketing clinical trials and post-marketing spontaneous reports, as well as individual patient risk factors, e.g. prior history of anaphylaxis, ability to recognize signs and symptoms of anaphylaxis, and ability to perform subcutaneous injections with Xolair pre-filled syringe or autoinjector with proper technique, according to the prescribed dosing regimen and instructions for use. Discontinue Xolair in patients who experience a severe hypersensitivity reaction. Malignancy. Malignant neoplasms were observed in 20 of 4,127, 0.5%, Xolair-treated patients compared with 5 of 2,236, 0.2%, control patients in clinical studies of adults and adolescents greater than or equal to 12 years of age with asthma and other allergic disorders. The observed malignancies in Xolair-treated patients were a variety of types, with breast, non-melanoma skin, prostate, melanoma, and parotid occurring more than once, and 5 other types occurring once each. The majority of patients were observed for less than 1 year. The impact of longer exposure to Xolair or use in patients at higher risk for malignancy, e.g. elderly, current smokers, is not known. A subsequent 5-year observational study of 5,007 Xolair-treated and 2,829 non-Xolair-treated adolescent and adult patients with moderate to severe persistent asthma and a positive skin test reaction or in vitro reactivity to a perennial aeroallergen found that the incident rates of primary malignancies per 1,000 patient years were similar in both groups, 12.3 versus 13.0 respectively. Study limitations, which include the observational study design, the bias introduced by allowing enrollment of patients previously exposed to Xolair, 88%, enrollment of patients, 56%, while a history of cancer or a premalignant condition were study exclusion criteria, and the high study discontinuation rate, 44%, preclude definitively ruling out a malignancy risk with Xolair. Acute asthma symptoms and deteriorating disease. Xolair has not been shown to alleviate asthma exacerbations acutely. Do not use Xolair to treat acute bronchospasm or status asthmaticus. Patients should seek medical advice if their asthma remains uncontrolled or worsens after initiation of treatment with Xolair. Corticosteroid reduction. Do not discontinue systemic or inhaled corticosteroids abruptly upon initiation of Xolair therapy for asthma or CRS with NP. Decrease corticosteroids gradually under the direct supervision of a physician. In CSU patients, the use of Xolair in combination with corticosteroids has not been evaluated. Eosinophilic conditions. In rare cases, patients with asthma on therapy with Xolair may present with serious systemic eosinophilia, sometimes presenting with clinical features of vasculitis consistent with Churg-Strauss syndrome. These events usually, but not always, have been associated with the reduction of oral corticosteroid therapy. Physicians should be alert to eosinophilia, vasculitic rash, worsening pulmonary symptoms, cardiac complications, and/or neuropathy presenting in their patients. A causal association between Xolair and these underlying conditions has not been established. Fever, arthralgia, and rash. In post-approval use, some patients have experienced a constellation of signs and symptoms, including arthritis, arthralgia, rash, fever, and lymphadenopathy, with an onset 1 to 5 days after the first or subsequent injections of Xolair. These signs and symptoms have recurred after additional doses in some patients. Physicians should stop Xolair if a patient develops this constellation of signs and symptoms. Parasitic Helminth infection. Monitor patients at high risk of GO-Helminth infection while on Xolair therapy. Insufficient data are available to determine the length of monitoring required for GO-Helminth infections after stopping Xolair treatment. Laboratory tests. Due to formation of Xolair IgE complexes, serum total IgE levels increase following administration of Xolair and may remain elevated for up to 1 year following discontinuation of Xolair. Do not use serum total IgE levels obtained less than 1 year following discontinuation to reassess the dosing regimen for asthma, CRS with NP, or IgE-mediated food allergy patients, because these levels may not reflect steady-state free IgE levels. Potential medication error related to emergency treatment of anaphylaxis. Xolair should not be used for the emergency treatment of allergic reactions, including anaphylaxis. In studies to simulate use, some patients and caregivers did not understand that Xolair is not intended for the emergency treatment of allergic reactions, including anaphylaxis. The safety and effectiveness of Xolair for emergency treatment of allergic reactions, including anaphylaxis, have not been established. Instruct patients that Xolair is for maintenance use to reduce allergic reactions, including anaphylaxis, while avoiding food allergens. Adverse reactions. Asthma. In patients greater than or equal to 12 years of age, the most common adverse reactions, greater than or equal to 1% more frequent in Xolair-treated patients, were arthralgia, 8%, pain, general, 7%, leg pain, 4%, fatigue, 3%, dizziness, 3%, fracture, 2%, arm pain, 2%, pruritus, 2%, dermatitis, 2%, and earache, 2%. In pediatric patients 6 to less than 12 years of age, the most commonly observed adverse reactions, greater than or equal to 3% more frequent in Xolair-treated pediatric patients, were nasopharyngitis, headache, pyrexia, upper abdominal pain, pharyngitis streptococcal, otitis media, viral gastroenteritis, arthropod bite, and epistaxis, chronic rhinosinusitis with nasal polyps. The most common adverse reactions, greater than or equal to 3% in Xolair-treated patients, included headache, 8.1%, injection site reactions, 5.2%, arthralgia, 3%, upper abdominal pain, 3%, and dizziness, 3%. IgE-mediated food allergy. The most common adverse reactions, greater than or equal to 3% in Xolair-treated pediatric patients 1 year of age and older, included injection site reactions, 15.5%, and pyrexia, 6.4%. Safety data obtained from adults, N equals 3, in this trial was limited. Chronic spontaneous urticaria. The most common adverse reactions, greater than or equal to 2% in Xolair-treated patients, for Xolair 150 mg and 300 mg respectively, included headache, 12%, 6%, nasopharyngitis, 9%, 7%, arthralgia, 3%, 3%, viral upper respiratory infection, 2%, 1%, nausea, 1%, 3%, sinusitis, 1%, 5%, upper respiratory tract infection, 1%, 3%, and cough, 1%, 2%. Injection site reactions. Asthma. In adults and adolescents with asthma, injection site reactions of any severity occurred at a rate of 45% in Xolair-treated patients, compared with 43% in placebo-treated patients. Severe injection site reactions occurred more frequently in Xolair-treated patients compared with patients in the placebo group, 12% versus 9% respectively. The types of injection site reactions in asthma studies included bruising, redness, warmth, burning, stinging, itching, hive formation, pain, indurations, mass, and inflammation. Chronic rhinosinusitis with nasal polyps. Injection site reactions occurred at a rate of 5.2% in Xolair-treated patients, compared with 1.5% in placebo-treated patients. Injection site reactions were mild to moderate severity, and none resulted in study discontinuation. IgE-mediated food allergy. Injection site reactions occurred at a rate of 15.5% in Xolair-treated patients, compared with 10.9% in placebo-treated patients. The types of injection site reactions included urticaria, discomfort, erythema, pain, and rash. All injection site reactions were mild to moderate severity, and none resulted in study discontinuation. Chronic spontaneous urticaria. Injection site reactions of any severity occurred in more Xolair-treated patients, 11 patients, 2.7% at 300 mg, 1 patient, 0.6% at 150 mg, compared with 2 placebo-treated patients, 0.8%. The types of injection site reactions included swelling, erythema, pain, bruising, itching, bleeding, and urticaria. None of the events resulted in study discontinuation or treatment interruption. Injection site reactions in healthy adults. In an open-label trial in healthy adults, in which the 300 mg 2 ml autoinjector was compared to the 300 mg 2 ml pre-filled syringe, injection site reactions, e.g. induration, pain, erythema, hemorrhage, swelling, discomfort, bruising, hypoesthesia, edema, pruritus, were observed in 24%, 16 out of 66 of subjects treated with the autoinjector, compared with 14%, 9 out of 64, of subjects treated with the pre-filled syringe. Cardiovascular and cerebrovascular events from clinical studies in patients with asthma. A 5-year observational study was conducted in 5,007 Xolair-treated and 2,829 non-Xolair-treated patients greater than or equal to 12 years of age with moderate to severe persistent asthma to evaluate the long-term safety of Xolair, including the risk of malignancy. The results suggest a potential increased risk of serious cardiovascular and cerebrovascular events in patients treated with Xolair. However, the observational study design, the inclusion of patients previously exposed to Xolair, 88% for a mean of 8 months, baseline imbalances in cardiovascular risk factors between the treatment groups, an inability to adjust for unmeasured risk factors, and the high study discontinuation rate, 44%, limit the ability to quantify the magnitude of the risk. Pregnancy. Data with Xolair use in pregnant women are insufficient to inform on drug-associated risk. You may report side effects to the FDA at 800-FDA-1088 or www.fda.gov/medwatch. You may also report side effects to Genentech at 888-835-2555 or Novartis Pharmaceuticals Corporation at 888-669-6682. Please see full prescribing information, including boxed warning and medication guide, at qr.qrhub.ly/XOLPI and additional important safety information at qr.qrhub.ly/XOLISI.